I agree with that.
Okay, so we're gonna get started. We have a lot to cover. Thank you very much for joining us tonight and sharing a little bit of your evening with us. Um, I really hope that you're gonna find this presentation very useful for your practice. And so basically, we are going to present Beyond the Clinical Crowns, a game-changer approach to orthodontic treatment planning tonight. My name is Dr. Sofia Arauz, and I'm a 3D Predict Scientific Director. This evening, I am honored to introduce our speaker, Dr. Jeffrey Miller. Dr. Miller is a board-certified orthodontist with over 35 years of experience. Dr. Miller has 13 offices in the Baltimore, Maryland area and 2 new offices in Florida with 1 more to come. The plumbing is still going. Dr. Miller is a big advocate of alveolar-focused orthodontics, which attempts to direct our attention to the underlying bone anatomy as a consideration when developing a treatment strategy for your orthodontic patients. For this purpose, Dr. Miller takes a CBCT on all his patients and uses 3D Predict for all his aligner cases. Knowing that tonight's attendees, they all own a CBCT, it is our objective that at the end of this presentation, you will be able to see the value of taking into consideration more of your patient's anatomy for your day-to-day orthodontic treatment, and will know exactly how to use this information for a sound treatment plan. Please feel free to ask questions at any point. You can post them in the chat, or you can send them directly to me privately. You can also wait to ask them during allocated questions sections for Q&A. So without further ado, please welcome Dr. Jeffrey Miller. Dr. Miller, the digital floor is yours.
All right. Well, thank you so much for the opportunity to speak to all of you tonight about how cone beam CT is not only changing the way orthodontists treatment plan and diagnose their cases, but also how our finished results are evaluated. And if you think about it, the cases that are being treated today with possibly a cephalometric panoramic evaluation, how are those cases going to be evaluated in 5 or 10 years? My money is that they're going to be evaluated by cone beam CT. And throughout this, it's a fairly short talk this evening, and I'm really just hit on some of the points on why I think this is valid technology. I'd like to thank the sponsors this evening, 3D Predict Aligners. They have some artificial intelligence that makes their aligners more predictable with less refinements. I personally find their aligners exceptional, but mostly because with their aligner system, I'm able to use a cone beam CT overlay, and the virtual treatment model incorporates the actual root anatomy and the underlying bone anatomy. In that respect, I believe it's a game changer. I'd also like to thank Prexion. Prexion makes some fantastic cone beam CT machines. If anyone has any interest, Oliver is extremely knowledgeable about cone beam CT. His email's up there, cell phone. We use these machines. We've used other machines, but we like the Prexion the best. The third sponsor this evening is Orthodontic Associates. We're looking for another orthodontist. So if anyone has any interest in coming to Maryland or just talking, we're more than happy to entertain you. Email tjross@orthodonticassociates.com. If during this evening you have any questions, please chat those questions to Dr. Arauz, and she'll forward the questions to me. As far as what we're going to talk about this evening, it's a few things worth mentioning, some background information, an overview of cone beam CT, and then how do we use this information And then if time allows, we'll go over a case example. Okay, first of all, I'd like to, just cover a few things. I do receive an honorarium from the sponsors. At least 2 of the 3 sponsors provide honorarium. I do not consider myself an aligner expert. Like everybody else, I do aligners in our practice, but I don't consider myself an expert in the nuance associated with aligner mechanics. And thirdly, virtual simulations may not represent exact outcomes. And I think that should not be a surprise to anybody. As healthcare providers, our first obligation to our patients is to do no harm. So if you look at these 2 sagittal views of lower incisors, the patient on the left is pre-treatment. That lower incisor is pretty much centered within the alveolar housing properly. Patient on the right was treated with Invisalign, and that root, although cephalometrically may be, properly positioned, the root does not comport with alveolar housing. It's been dehisced or pushed out of the alveolar housing. And I believe that that is not a healthy situation for the tooth. As orthodontic specialists, we're constantly balancing between stability, aesthetics, occlusion, and periodontal health. We're looking at all these things and trying to figure out what the appropriate treatment plan is for our patients. If you notice, I did not mention airway, TMD, or facial beauty. These things are not correlated with orthodontic treatment in our scientific refereed literature. I know there's a lot of talk about airway and extractions, but that correlation assumes that whenever you extract teeth, you're constricting the arch to a smaller dimension. And as an orthodontist, you should know that even with extractions, many times the arches are expanded. So, these things to me don't weigh much in my treatment planning decision when you compare them to stability, aesthetics, occlusion, and periodontal health. A lot of what I'm talking about this evening is related to cone beam CT technology. But what if you do not have a cone beam CT in your office? I assume that if you're listening, I was just curious, how many people have cone beam and how many do not? But if you do not, I think there's a strong argument that you should have the technology. But even if you don't, it's quite simple to have one of your colleagues down the street take a cone beam for you. We get patients coming into our office all the time. They want a cone beam, and we take the cone beam for them. We put it on a thumb drive. We have them sign a disclaimer that we are not evaluating the cone beam. We are just providing the service. And that seems to work out well. This is Dr. Joe Nemeth. He's a periodontist from Michigan. He has his own YouTube channel, and he doesn't mix his words when he says that gingival recession and orthodontic treatment are related. And I think anybody with a brain that practices orthodontics realizes there is a correlation between gingival recession and orthodontic treatment, but we're not really sure, definitively what that means. This is a study out of Hebrew University in Jerusalem by Dr. Hashu and Stabholz, where they looked at first world countries and the prevalence of gingival recession. This study concluded that the 2 main predisposing factors are thin gingival biotype and bone dehiscence caused by labially displaced roots, meaning orthodontically induced dehiscence led to a higher probability of gingival recession. This is a study from Rodriguez et al., where he looked at the thickness of facial bone that's labial to the upper incisors. And in summary, most patients do not have very much bone facially. So if you're going to use a treatment strategy that uses expansion, you're very likely to dehiss the root through the facial cortical plate. Now, I'm aware that there are systems like Damon, fast braces, 6-month smiles that claim that they use some kind of light physiological force and the bone modifies as the tooth is expanded with a light force. If that's the case, there's no literature that supports that that I'm aware of. And believe me, I look at thousands of cone beam CTs and I see the results of these types of indiscriminate expansion techniques, all in an effort to avoid, like an extraction therapy. And it's not part of this discussion tonight, but I think you get the idea where I stand on those systems. Inevitably, an orthodontist will come to me during a talk and say, hey, Jeff, I've been practicing for 25 years and I haven't seen the gingival recession that you're speaking about in your presentation. And my first question to them is always, well, what is your retention protocol? And the answer is always like something along the line of, I give them 2 sets of suck down retainers and I tell them, call me if there's a problem. Well, you rarely see the gingival recession during active orthodontic treatment. It takes approximately 5 to 15 years for that gingival recession to occur secondary to root dehiscence. And there are other factors involved: oral hygiene, the quality of the tissue that the patient's born with, the overall health of the patient. And just like this 112-year-old woman that's a chain smoker, and she was still alive in 2016, you could have another person smoking the same volume of cigarettes and they're dead from lung cancer at 35. A biological system can react different to different types of insults. But I think for the purpose of this discussion tonight, that we can agree, or we should agree, that a healthier tooth has a root that is completely encased in bone. In other words, that root is completely surrounded with bone with no defects. There's no dehiscence, no fenestrations, no periodontal defects. It's fully encapsulated. And that the value of cone beam CT to orthodontic specialists is directly related to our better understanding of dehiscence and fenestration. Okay, we know that if you orthodontically push the root through the cortical plate, it's going to result in dehiscence and fenestration. And what we don't completely understand is at what point it becomes pathology. In other words, can you push, 2% of the root through the cortical plate and would that tooth still be healthy? Probably. But when you start pushing a tooth out a third or a halfway out of the alveolar housing, I believe that's problematic. But for the purpose of this discussion, again, I think a safe assumption is that a dehisced root is more susceptible to tissue dehiscence when it's compared to a non-dehisced root. It's not a stretch. I don't believe anyone should have a problem with that. And by extension, dehiscence and fenestration should be considered a negative consequence of orthodontic treatment. And that doesn't mean by any means that as orthodontists, we're never going to dehiss or fenestrate a root. We do it every day. But it's the magnitude of that dehiscence that I think is significant. Small dehiscence that are comparable to naturally occurring dehiscence probably do not affect the long-term health of the tooth. But when you start pushing the root out of the bone, where it's halfway out or a third way out, I think that's a different category of dehiscence and fenestration. This is a study by Capella and Nervina. This is an excellent study. They looked at non-extraction expansion treatment. and they concluded there was considerable loss of alveolar buccal bone following treatment. You can look at the axial views of this patient before and after treatment, and you notice the generalized pattern of dehiscence from really the first bicuspid to first bicuspid. Here's a patient that just recently came into our office, 25 years post active orthodontic treatment. She told me that about 10 years after active orthodontic treatment, she saw that, noticed that her central incisor, lower central incisor stripped away, and she had a graft. Now, one of the things that you may not be aware of is that when you see this type of thing, the orthodontic, or most orthodontists that I talk to, assume that they can take the tooth and retract the root bodily into a proper alveolar housing. That if the tooth was pushed forward, then it makes sense that I'm only going to need to retract it to get it back into the proper bone. Unfortunately, that's usually not the case over time, because that alveolar housing modifies, it adaptively resorbs. So the only way you'll know if that tooth has proper bone lingual to the root is by taking a cone beam CT. A SEP is not going to show you that. So here you can get an idea of what the 3D volumetric rendering shows. And here's tooth number 25. You can see how the root is probably halfway out of the alveolar housing from an axial view and from a sagittal view. This is taken approximately halfway down the root. Now, if you compare that to the axial view that Nervina and Capella showed in their study, you could see they're almost identical. And I don't believe that you could tell from the cone beam CT slice whether or not there's tissue recession or not. They look exactly the same radiographically, whether or not the tissue is intact or the tissue is gone. So here is a case that was posted on Facebook. Clearly that incisor is no longer properly in the alveolar housing, but look at the tissue, it's still intact. And if you think that these teeth are not compromised, I would say, it's a good chance you need to go back to dental school. And just from a comparison, here in that same patient, tooth number 25, which is halfway out of the alveolar housing, tooth number 24 is reasonably within the alveolar housing. It can give you an idea what, the difference, what they look like. Here's a study from Morales et al., where they looked at non-extraction alignment with self-ligating brackets led to arch expansion associated with tipping of teeth. Expansion related to alignment resulted in horizontal and vertical bone loss at the incisors and mesiobuccal root of the first molars. Thinner bone thicknesses and more severe crowding before treatment increase the risk of buccal bone loss. Makes sense. The more crowding you have, the more expansion is needed to decrowd the arch, and therefore the more dehiscence and fenestration or bone loss would result. Now, interestingly enough, this was a study that for some reason was done on the upper arch. And everybody knows that the lower incisor or lower anterior region is the area where you have, kind of the limiting factor in orthodontics. It's where you have the thinnest bone. But all these studies, they point in one direction. And that is, if you overexpand or you move the root orthodontically through the cortical plate, it's going to result in dehiscence and fenestration. There's no refereed scientific literature that I am aware of. Now, there may be something out there, I just don't know about it, that supports this idea that if you use a light physiological force, that the bone modifies as the tooth is expanded. Okay, so if you take a look at the gentleman in the white t-shirt, how would you describe his behavior? Is he acting normally? He looks like he's sitting on a bench and he's talking to a bronze statue. But you're making your assessment based on a two-dimensional photograph. If you took a closer look at him, you would see that he's wearing a Bluetooth earpiece, and he's probably just talking to one of his friends on the phone. This would likely change your assessment of his behavior. And it's exactly the same situation when you compare the inadequacies of 2D cephalometrics to the capabilities of 3D cone beam CT. This is a 3D volumetric rendering, but really the heavy lifting occurs at the individual slices in all three planes of space. Okay, you have the axial, sagittal, and coronal views. We all know, or at least we should all know, about the literature that's related to changes in lower inner canine width. It pretty much points in one direction, and that is that the maintenance of the original unchanged inner canine and intermolar width is therefore critical to the long-term stability of orthodontic treatment. But you rarely hear much discussion about long-term stability in the orthodontic specialty arena anymore. And probably because of bonded lingual retainers. Bonded lingual retainers allowed the orthodontist to violate many of these traditional orthodontic theories, and at least in the short term, get away with it. I don't believe they get away with it long term, because when you take a tooth and you expand it through the limit of the cortical plate, and then you stick a fixed retainer on there, you're likely to have consequences that are way worse than relapse. You have crazy things happen to these roots. Also, we're all familiar with Andrew's 6 keys of normal occlusion. I'm not going to review that article other than to say he recorded where Mother Nature placed teeth in what he called ideal or normal occlusions. So when you're at an orthodontic conference and the speaker is saying things like, I prefer my bicuspids to be on a little more upright angle because I think it's more appealing, more cosmetically desirable. You know, what evidence backs that claim up? You know, to me, it's like the kid on the playground that makes the rules up as he goes along. But one thing is abundantly clear when you start looking at cone beam, and that is you realize that the alveolar housings not only vary between different individuals, they can vary significantly between different segments of the same individual's arch. So if the anatomy of the alveolar housing varies, you know, as orthodontic specialists, what do we do about it? Cephalometrics, for the most part, ignores the variation in the alveolar housing. Should the patient on the left be treated the same way as the patient on the right? In my opinion, no. I think it's an important consideration. And if you think about cephalometrics, I mean, this is technology from the 1950s. It hasn't really significantly changed since the 50s. And for the orthodontists that, you know, kind of, I'm not going to say anti-cone beam, but they, you know, they don't see a value in cone beam. It's because they're taking the cone beams and they're recreating the 1950s technology of a pan and a ceph. Once you realize that cone beam is about looking at individual teeth and the alveolar housings that support those teeth, everything changes. And it doesn't make orthodontics easier. It makes it more complex, because now you have another consideration to deal with in your juggling act. And, you know, there is a silver lining, because the more complicated orthodontics becomes, the less likely the non-orthodontist will get involved in it. You know, the one great thing about, I guess the one brilliant thing about companies like Invisalign, they dumb down orthodontics to the point where it's just, you know, taking a digital scan. It's the mechanical alignment of the clinical crowns with no consideration of the underlying bone anatomy or the roots. So just to drive this point home, here is a patient with a class 2 division 1. She's got a retained primary tooth, peg laterals, traditional, you know, she doesn't want surgery. This is a kind of textbook upper first bicuspid extraction case. Here is the reconstructed cephalometric x-ray. I don't take cone beams in occlusion anymore. I'm not trying to reproduce a Ceph. I could care less if the lower incisor is 92 degrees to the mandibular plane angle, if the alveolar housing is at 120 degrees. Okay, I'm trying to keep those teeth as best as I can within the alveolar housing. So this is the reconstructed cephalometric X-ray and the reconstructed Panorex. And by the way, if you're looking for a cone beam CT, there's really no value in the cephalometric attachment because you can recreate the Ceph very easily with the 3D volumetric rendering. So I asked 3D Predict to simulate 2 treatment approaches. One was a textbook, take out the 2 upper buys, achieve canine, class 1 canine, and proper overjet and overbite. And plan 2, leave the occlusion in class 2, line things up, get rid of the primary tooth, and set this patient up for veneers. Which of these treatment plans is more appropriate? And do we actually have enough information to make that decision looking only at the pan and Ceph? If you take a look at this patient's cone beam, we're looking at the upper right central here. So we're compensating the view. So we're looking either parallel or perpendicular to the long axis of the tooth. Okay. So if we look at the upper right central and we look, this is taken halfway down the root. How much bone is there lingually to retract those teeth? Not very much. So if we compare it to it, this is just another random patient, and you look and you see, this patient has more alveolar real estate that could probably withstand extraction and retraction of the upper incisors. From a sagittal view, and you look at this, I think the last thing you'd want to do is retract those upper incisors with 2 upper bi extractions. And you're not going to get that information from the cephalometric X-ray. And just from a comparison, this is that same patient from a sagittal view. You see that this patient has plenty of alveolar real estate to retract those and upright those teeth. So when we look at a virtual simulation model that uses both bone and roots, and these are actual root anatomy and actual bone anatomy, these simulations do show, potential consequences of what could happen. And with 3D Predict, because sometimes it's not clear whether it could be a 0.5 millimeter or 0.6 millimeters of bone or not, they have color mapping that show you where the thick and the thin bone is. So when you see red, it could mean that there is bone there, or very thin bone, or there is no bone. It's just hard to tell. But when you look at this case, by using this type of virtual model, I don't believe any orthodontist is still going to recommend this treatment after seeing something like this. But you may not be mindful of it without cone beam CT. And this technology, really kind of helps orthodontists, at least in this case, what not to do, which is as important as what to do in many cases. So when we look at plan 2, where we just left a patient in a class 2 relationship, the occlusion is not ideal, but we kept the teeth more properly situated within the alveolar housing or the alveolar trough. The cartoon gingiva that's painted on by these other aligner companies have no basis in reality. They're all going to look perfect. And you could get fooled thinking that this is appropriate treatment. You're not going to be able to be fooled when you're starting to integrate cone beam CT in these virtual models. Now, are these virtual models using cone beam CT perfect? No, of course not. They're basically static models. 3D Predict does have some artificial intelligence that can add up to 0.6 millimeters of bone, but basically they're static. They don't show the changes to the interseptal bone that could occur, but those are minor. They're not major changes. And pretty much what you see here in plan 1 is something close to what you're going to get. This happens to be the wife of a dentist. And this poor lady is losing her upper front teeth, and she's already lost some of her lower teeth. And you could see what that alveolar housing looks like after resorption. There's not much of a chance you can get an implant in there, unless you do some heroic bone grafting. So when we talk about the juggling act that we all do each day, in plan 1 versus plan 2, stability probably about the same. Aesthetics, I think you might be able to argue that plan 1 may be slightly better than plan 2. Occlusion, clearly plan 1 is better in terms of occlusion, but I think periodontal health trumps the occlusion in this particular case, because retracting those upper teeth is likely to do long-term damage. But you're not going to know about that, or you're not even going to be mindful of it without this technology. Here's a case that just recently came into our office. She was treated by one of the local orthodontists, who actually I have a lot of respect for. He's an excellent orthodontist, but he uses cephalometrics. And he treated this patient to normal torques based on either Andrews 6 keys or whatever bracket subscription he has. Patient was an excellent patient, showed up for every visit, finished on time. 1 year after treatment, she noticed that the lower left central incisor tissue stripped away. She goes to the periodontist. The periodontist says the tooth is hopeless. They extract the tooth and refer the patient to us. So here is the original records from this patient. Here's the pan and the ceph. And keep in mind that this patient's only 28 years old. So this patient is what you call a compensated class 2. In other words, it's a class 2 skeletal pattern with dental compensations so that the occlusion's class 1. This is pre-treatment. These types of patients generally have flared lower incisors to compensate, but they also have flared alveolar housings as well. So you can see what happened here. This is the cone beam CT we took of her when she first came in after the tooth loss. You can kind of see how these lower incisors were uprighted with total disregard to the alveolar housing anatomy. Now, if you took a ceph of this patient, you measured these incisors, they would be consistent with normal ceph measurements. But the patient's alveolar housing wasn't normal. She happened to come in today, so I took some pictures. What we ended up doing with her is we put Roth prescription brackets on the incisors upside down so they would provide lingual root torque. The first wire we put in was a 1622 9-tie. We use an 18 slot on the anterior teeth. We sent her, before we started orthodontics, we sent her for grafting. She got the bone graft for those anterior teeth. And this is 6 weeks into treatment. We dual cable lower incisor space closure to get the space closed as quickly as possible so we don't lose bone. And you could see, I think she's gonna be fine. So with the lower incisor, she does have a slight Bolton, to add to it. But here's another interesting thing. Because you can manipulate these 3D volumetric renderings, you can get perfect superimposition of the right and left sides of the head to get a really good ceph. This is that same 3D volumetric rendering with slightly turned and tipped, and you can see the vast difference in terms of those lower incisors. The image on the right shows those lower incisors to be reasonably well in bone, where on the left you can see they're clearly sticking out. And when we take cephs on patients, we don't know that head is perfectly aligned up with that Ceph machine. Most often they're tipped or, turned or, whatever. Here's another case. This is a retreatment case that recently came in. Actually, we took his, we used 3D predict aligners on him. We took his attachments off today and put them in retainers. But you can see this is his pre-retreatment cone beam CT. He's also a compensated class 2. He had previous orthodontics with upper bicuspid extractions, but notice the lower alveolar housing here. It's procumbent, it's protruded, but so are his teeth. Here is the cone beam CT we actually took today. And you can see the 3D predict virtual model made us mindful of this. It's not irregular alveolar housing anatomy, because if alveolar housing anatomy varies tremendously, but it made us mindful to keep the teeth centered within that alveolar housing and not to try to upright them so that they comport with Andrew 6 keys of normal occlusion. So here is the virtual model that shows the finished result. You see the roots are well kept within the bone. And if you compare that to the case we just discussed, the anatomy of the alveolar housings here is similar, just two completely different treatment approaches. And I would say the patient that lost that central incisor was more of a cephalometric treatment approach versus an alveolar, more alveolar focused treatment approach. That, if they would have used that for sure, that patient wouldn't have lost those teeth. And here you can see our finished result, 11 trays, no refinements, everything went as scheduled, no hiccups during this treatment at all. So how do we use this information? Well, we all know what a crown-based aligner system is. That's what's readily available in the market. We take a digital scan, we submit that scan with photographs to a digital lab, we get back, a virtual model that really the only consideration for treatment is the mechanical alignment of the clinical crowns. Now, as orthodontic specialists, we know there's more involved. But when you think about all the general dentists out there that are doing orthodontics, their worldview of orthodontics is the mechanical alignment of the clinical crowns. It doesn't go past that for the most part. They're not concerned about stability. They assume that if the model looks good, the treatment's good. Okay, so it's a completely different level of orthodontics when you talk to general dentist versus orthodontist. When we talk about alveolar-based aligner treatment, we're looking at the same digital scan, but merging it with the DICOM file associated with the cone beam CT, and it produces a virtual model that in 3D Predict's case has actual alveolar bone anatomy and actual roots. Some of these companies will stick on like a stock root to a clinical crown. They don't do that. And as I mentioned before, they have this color mapping available where you can kind of see where the thin bone is. This technology is available at different levels by Spark aligners, SureSmile, and 3D Predict. I've never used Spark aligners, but I took a look at their website. I mean, it's like using Windows 98. I mean, it's not a completely cone beam integrated model. SureSmile has had this for a long time. We actually beta tested SureSmile aligners using cone beam CT, and we now use 3D Predict aligners. We're really happy with them. I believe that they offer something that the other aligner companies do not. And, as I very strongly believe, as orthodontic specialists, we need to get past being clinical crown jockeys, and we need to start looking at the root and underlying bone, mainly for the survival of our profession. Our profession has been dumbed down to the point where acceptable treatment seems to be the mechanical alignment of the clinical crowns. And as we know, orthodontics is way, way more involved than that. So here, I'm going to show you two cases to compare. This is an adult retreatment case. This case, I treated, years ago. I don't even actually remember when I finished her, but I know she walked around with 2 broken lingual bonded fixed retainers for several years before coming in for treatment. And, this is a no-brainer case. This is I would say, as simple as they get. But I like this case because it shows, we don't really have a lot of tolerances in the lower anterior region. So, I believe this is a different level of treatment. And I'm going to show you another case that I believe is similar, and you show what happened. So let's take a look at the lower right lateral incisor. This case was treated with 10 trays. There was no refinement needed. It was a total of 20 weeks. Patient came in. This is the original cone beam CT that we took. As you can see, we're slicing, we're focusing in on tooth number 26, the lower right lateral incisor. And here you can see what the tooth looks like within the alveolar housing. Remember, this tooth is slightly lingual relative to the other teeth in the arch. Okay, so if we measure the thickness of the root, and with cone beam CT, as long as you're perpendicular parallel to the root, these measurements are accurate. The root has a buccal lingual width of approximately 5.86 millimeters halfway down. And in that same spot, the alveolar housing is about 7.55 millimeters. That leaves you approximately a millimeter, 0.7 or millimeter, 1.69 millimeters of wiggle room. Okay, it's not a lot. So here on the left is the initial pre-retreatment 3D volumetric rendering, and on the right is the virtual model before any treatment has been initiated. So you can look at these two and you can see they're pretty much identical. I can't find any area that I would question whether it's accurate or not. But when you use these virtual models, one thing you have to do, or one thing you should be doing, is you should be comparing the virtual outcome, and all the virtual outcomes always look good, right, to the actual outcome. What exactly happened? Did you accomplish your goals? Did the movement that was proposed in the virtual simulation actually happen clinically? So here is a cone beam CT taken with the final tray. So we took the cone beam before we took off the attachments because we want to see if we need to torque or touch up anything with refinement. So here you can look at the pre-retreatment and the 20-week progress. And you can kind of get an idea, what happened, but clearly that root is still within the proper alveolar housing. And if you think we expanded the alveolar housing by tipping that tooth, you can look at the measurements, pre-treatment and 20-week progress. And the pre-treatment is 7.55 and the 20-week progress is 7.6. 0.05 millimeters is nothing. There's a margin of error there. So here you can look at the clinical photos and you can see how we did achieve alignment. You can look at the axial view and you can see that root still is maintained within the alveolar housing. And that's because we used a combination of interproximal reduction and slight tipping of that tooth. Very small, minor adjustments go a long way in keeping these teeth within the alveolar housing. Okay. And I would say this was a successfully treated case based on the cone beam CT. Now take a look at this case. Okay. This patient was treated by another orthodontist. It was sent to me by an attorney that specializes in dental malpractice. He wanted me to look at it and get an opinion. And I'm going to show you the correspondence from the attorneys. So this patient was treated with Invisalign. You notice that she has gingival recession pre-treatment. She goes through the trays, and during treatment, she loses tissue on the facial surface of those lower incisors. Okay. She goes to her attorney and tells her attorney, look, I didn't have this problem before orthodontics. The attorney sends the records to the second attorney who does dental malpractice, and that attorney ended up sending the case to me to look at to see if I thought anything was wrong. And, you know, just to keep you hanging, I thought this orthodontist did everything properly. I didn't think it was just an unfortunate outcome. So this is the clinical photos. Here's the notes from the orthodontist. If you look at the bottom line, it says no elastics, keep class 2, flare upper and lowers into alignment, and then IPR 0.3 millimeters upper and lower 4 to 4 to reduce the dark triangles and reduce the flaring. I assume that's what he meant here. That's a proper treatment plan. I would say an improper treatment plan is if someone tried to use class 2 elastics to try to correct the overjet. There's not enough bone there. She already has tissue recession. So this is the only records I got. This is after she had the graft. It looks like the graft is successful. And now they're looking to sue somebody. So here are the notes from the periodontist. Nothing, that interesting here, other than saying that she did lose tissue and she was mobile. So here is the letter from the first attorney to the second attorney, basically saying how great this woman is, how nice she is, how beautiful she is, and that she never had any problems before she saw the orthodontist. Here's the email to me. Can you take a quick look? Is this worth a more thorough malpractice evaluation? And actually, I review cases. I don't testify, but I review cases for this guy. This is the first orthodontic case I've seen. Okay, so. And then here I emailed him back, Rich, in my humble opinion, it was more of an unfortunate outcome. The orthodontist was careful not to move the lower incisors facially, and not sure there was any other reasonable treatment alternative other than no orthodontic treatment. However, I think if he used the technology that's available, 3D Predict, he could have at least avoided the gingival recession. I don't know that definitively, but I believe that would have probably had less chance to have the gingival recession that occurred. Or if he used cone beam CT, he at least could have informed the patient that if we do this type of tooth movement, there's no, there's no bone down to the apex of the tooth, and there's a good possibility you might need a graft at some point during treatment. I'm going to just stop here and ask if anybody has any questions. And if you want, I can go through this case example I have, but be more interested in hearing not only questions, but feedback from the orthodontists that are, listening today, and just, kind of go from there and play it by ear. I know I did say that the presentation was limited to an hour, so we're right at the hour now.
I have a quick question.
Sure.
I was wondering, so with everything that you said, why isn't it that a company like Invisalign not using or have not incorporated this technology into their system?
It's a really great question, and I'm not sure I even have an answer. But Invisalign is, the 5,000-pound gorilla in the aligner industry. They have the greatest technology, second to 3D Predict, of course, but I'm not sure why they don't have it. They have made announcements that they are going to incorporate some kind of BCT overlay. I haven't seen it yet. I don't know if it's available. But I mean, there's no question that this is the future of orthodontics. Sometimes people have a hard time digesting it. And I would put a challenge out to my orthodontic colleagues and say, if you're doing aligners, why aren't you using this technology? It's a differentiator. it differentiates you not only from the general dentists in your community that are doing aligner treatment, but the do-it-yourselfers. And I make sure I explain to every patient I have the technology I'm using and why I'm using the technology. So they don't think that they're getting the same aligner system as the guy down the street that's doing it for $2,500. I mean, we're charging almost 3 times that much. So I want to know that you got to sometimes tell people what they're spending their money on. And I think as orthodontists, we feel like we're dedicated to our patients and we're trying to do the best we can. But sometimes you really need to tell them, what they're paying for. It's a good question, Dr. Miller.
We have another question on the chat. Does a CBCT image over or underrepresent actual bone present?
That's a very good question. So the studies in the orthodontic referee literature say there's plus or minus 0.6 millimeters. Okay. When you hear speakers talk about cone beam CT, they almost imply that it's always minus 0.6 millimeters. It's not accurate. It's bone measurements are off maybe by a half a millimeter or so. Okay, and then there's differences in studies that use dry skulls versus live patients that have had flap surgery, things like that. But when you talk about as an orthodontist, let's assume that it under evaluates the bone. Let's assume that the bone measurement's always 0.6 millimeters shy, which is not the case because it could be 0.6 millimeters over. What does that mean clinically? If you see a patient pre-treatment and you're looking at the lower canines and you see something that looks like a root dehiscence, and you say, well, there's no root dehiscence on these canines, maybe there's 0.6 millimeters of bone there. That's a thin shell of bone there. I don't think it changes a thing we do orthodontically if you're properly treatment planning in that case, because whether you have 0.6 millimeters of bone there or you don't, what that tells you is don't expand those cuspids any more than they already are, because you got virtually either a dehiscence or you have very, very thin bone. So in terms of making treatment decisions, I don't think it really makes that much difference. Now, in terms of evaluating finished cases, it's a kind of a rationalization, I believe, for poor treatment to say, well, studies show that the 0.6 millimeters of non-visible bone there every time you see a root dehisced or fenestrated. And that may be true for minimal or minor dehiscence, but it's a bone measurement. When you see that root that's halfway out of the bone, which or out of the alveolar housing, which is maybe 3-4 millimeters, that 0.6 millimeters is really insignificant. And it's a good question, and it's almost I don't want to be critical, it's almost a rationalization for I think poor orthodontic treatment.
No other questions on the chat.
Okay. I mean, do you want me to go through these case examples or this case example, or would you?
I mean, it
Otherwise, I'll
depends
just-
on everybody on the chat. Dr. Miller, how long do you think it's going to take?
It's going to be another 10 minutes, and then I have just the ending slides with the typical stuff.
Dr. Sammy has a question, actually.
Sure.
He said, we do the same thing with Fix. What system are you using for that?
It's true. I mean, I use 3M's products for fixed, and we use an 18 slot with Roth prescription and a 22 slot in the posterior. But I don't put in a full thickness wired to express torque without first knowing where the alveolar housing anatomy is. But he's right. The only difference I would say between the fixed and the aligners are that you can't do independent torquing with a fixed system because you have adjacent teeth that are affected by the torque of the one tooth. So if you want to torque the lower central incisor, that torque setting on the lower central incisor is going to affect adjacent teeth in some manner because they're connected by the wire. Where with aligner treatment, you have more of an independent ability to torque individual teeth. If providing the aligners properly express the torque, that's a whole nother discussion.
Thank you. So I think we can keep going if you want to present your case samples.
Okay, so this is a case, an adult case. I'll go through it quickly. And he came in, he's a class 3 skeletal with compensations to his teeth to create a class 1 occlusion. He's compensated class 3. This patient ideally is a surgical case. There's no question about that. He's a doctor. He was at Hopkins Hospital in Maryland. Now he's at University of Pennsylvania. And, we simulated different treatment approaches for him. So here is his digital scan. Here's the recreated pan and ceph. Here is his volumetric rendering. If you take notice, you see that he has some clefting associated with the upper right lateral incisors. Just keep that in mind. So I asked 3D Predict to simulate 3 treatment approaches, a non-extraction approach to attempt to keep the teeth and the roots within the alveolar housing, a treatment approach where we extracted 4 first bicuspids and asked the digital lab, make every effort to keep the teeth within the alveolar housing. These are, obviously we had a cone beam which we submitted with this case. And then we asked the digital lab to submit a non-extraction approach using Andrew's 6 keys of normal occlusion. If you send a case for aligner therapy, you're going to get something that approaches Andrew's 6 keys of normal occlusion, unless you give specific instructions about torque. Okay, so if you submit this case and say non-extraction, this is pretty much what you're going to get back. So when you compare these, you can see that, they cosmetically, from this virtual simulation model, the non-extraction 6 keys and the extraction look about the same. The alveolar housing non-extraction approach, where shows the upper teeth perhaps a little bit procumbent. So if we look at these 3 scenarios using 3D Predict's deep scan, and we look at where the roots and bone are, you can see that here they made every effort to keep the teeth centered within the alveolar housing. But if you remember, there was clefting around the upper right lateral incisor. And, you would expect that would be the result unless you could convince the patient to do some kind of grafting ahead of time. When you look at the torque settings of these incisors, the torque of the upper right lateral is not the same as the central because we're trying to keep these teeth centered within the alveolar housing. Also simulate this case using 4-by extractions. This is actually what I ended up doing. To me, this was a better looking result and I felt more stable. So here you can see, although we got things lined up, the reason these upper incisors did better is because the upper lateral incisor required very little buccal lingual movement. Because we had the benefit of the extraction space, we're able to align the teeth around the lingually positioned lateral incisor. However, we did end up potentially dehiscing on the lingual of the lower incisors because they needed to be retracted. Now, in this particular case, we do have parallel roots because, like I said, everything's treated to the weakest link, which in this case is the the upper right lateral incisor. So if you look at these two scenarios and then you compare them, how do you make a decision based on stability, aesthetics, occlusion, and periodontal health? For me, the aesthetics of the extraction case looked much better, and the stability of the extraction case, I believe, is superior to the non-extraction. So, that's, I guess, a couple of the reasons why I went that way. But let's look at, and, I don't have anything against the non-extraction approach. I mean, this patient more married to the retainer, that's all. So let's look at it if we did a Andrews 6 keys of normal occlusion approach. And here they torque the teeth to achieve what I guess would be considered normal torque. And you can see how these roots really just came completely out of the bone, especially the upper right lateral incisor. There's probably very little bone holding that in anymore. And, I think this is an inappropriate treatment approach, especially knowing what cone beam CT will show. So here is that I showed this case in the beginning, but this case was posted on Facebook. This is exactly what was done here. They tried to torque their way out of a procumbent incisor. And notice the tissue is still reasonably intact. So, what do you do at this point? There's not much alveolar housing left. Are you going to go in there and graft and pray to God that you're not going to do any more damage? If I saw that case, I'd send it to one of the qualified general dentists down the street for me to finish it up. Anyway, here you go. So here is, if you're interested in 3D Predict, there's a code here you can scan, or you can go to demo.3dpredict.net /. Also, we have that 3D Predict has a upcoming webinar with Dr. William Dabney. It's excellent. He talks about aligners. He's much more versed on aligners than I am, and he has a lot of interesting things to say. If you're interested in a cone beam CT, I would highly recommend you touch base with Oliver. Keep in mind the Prexan can also arrange to have someone purchase your existing digital pan Ceph machine while they still have value. In another few years, they're probably not be worth much. So they can, you can trade that in and get a cone beam CT machine, but it starts with a phone call. If you need CE credits, you can email sophia.aruz@3dpredict.com. If you have any questions or comments for me, my email is ortho606@gmail.com. Thanks so much for your attention tonight. I really appreciate the time you spent today listening about cone beam CT and 3D Predict. And I hope you found the presentation, of value.
Thank you very much, Dr. Miller.
You're welcome.
And we do have some questions on the chat, and we're going to open for some questions in a second, but I just want to finish by thanking Dr. Miller once again. We are very honored to have him as a speaker. I don't think I have met any orthodontist who have the years of experience with CBCT that he has. So he really is an expert in the area. I also want to invite you to our educational events, because the next one, like Dr. Miller was mentioning, is with Dr. William Dabney, who is also a very experienced orthodontist. He has started taking CBCT for almost all his cases with us. And he is going to talk about the finance of aligners in your practice and how incorporating CBCT into that process actually can make your practice more profitable, because we're going to be lowering the rate of refinements, which is what actually eats at your profits at the end. So with that being said, the question that we have on the chat, which I think it's funny because we were just talking about it a lot this past few days, is Dr. Sammy asks, how does this compare to Spark with their CBCT?
Well, you can go on Spark's website and look at the video they have. What they actually have is you take the virtual simulation that just has the clinical crowns, and then you take your 3D volumetric rendering and you kind of superimpose the two. You try to line up the clinical crowns so you can see where the roots are. It's kind of bizarre that they would put that up there, but you can look and see for yourself, what that looks like. I think it's probably not used very much, if I had to guess.
I don't know if we have any other questions on the chat.
Thank you, Dr. Miller.
You're welcome. Thank you
And
very much.
actually, yeah, I just maybe wanted to add a comment on this question. And also like I think Zach asked why Invisalign does not do roots and bone. And first of all, this is it's very complex task to create 3D models, precise roots and bone 3D models from CBCT images. That it's not like easy, even like technologically, it's really complex. And so like, for sure, like we don't know why they don't do it. But first of all, it's not easy. And like second, for example, like some time ago, like Nokia was the market leader in phones, but then iPhone appeared. So we just see this like technological jumps in any industries. And so again, like even with Spark, it's more like 2D, like superimposition of like slices. And what we do at our technology, we use machine learning to create really precise 3D models of roots and bone, which you could easily incorporate in your treatment plans. Yeah.
Well, thank you.
Thank you, Marina.
And turnaround
So
time.
yes.
So once you submit like all medical records and prescription, you'll get this 3D plan within 3 business days. And once you approve 3D plan, you'll get aligners within 10 business days. We've done analysis for the last couple of months, and the turnaround time was 8.5 business days. But yeah, just usually once you approve 3D plan, within 2 weeks, you will get your aligners. Our aligners are manufactured in California, so it's like pretty fast. Thank you for your questions, Dr. Sami.
Yeah, thank you. So if there's no further questions, thank you very much, Dr. Miller. And thank you everybody for joining us tonight and spending some time with us. I hope you find this useful, and please don't hesitate to reach out to me or to your sales rep. We're gonna contact you via email anyway to send you some other information and hopefully answer any questions you may have.
Thank you.
Have a great evening.
Bye.